Hello, everyone. Welcome to the GI Issues in Prader-Willi Syndrome Perspectives. And we are introducing Dr. Ann Scheiman, who received her doctorate in medicine at the University of Cincinnati School of Medicine and completed her pediatric residency and pediatric GI and nutrition fellowship at Baylor College of Medicine in Texas Children's Hospital. She was full-time faculty within the Division of Pediatric GI and Nutritional at Baylor College of Medicine until 2000, when she moved to join the full-time faculty at the Department of Pediatrics Division of Pediatric GI at Johns Hopkins School of Medicine, but remained adjunct faculty at Baylor College of Medicine, directing the Prader-Willi Clinic at Texas Children's Hospital. Dr. Scheiman completed her master's in health science management at Johns Hopkins School of Business in 2005. Dr. Scheiman's focus of research interest has been in nutrition and obesity, with special areas of interest in Prader-Willi syndrome and non-alcoholic fatty liver disease. She has authored and co-authored to date approximately 89 peer-reviewed publications, in addition to book chapters. She has been honored to serve on the advisory board of IPSO and PWSA USA and volunteered for several years on the medical crisis team for PWSA USA and presented at regional, national, and international PWS conferences. Today's session is going to be a taped session to avoid any technical difficulties with feed. And then we will be coming back with Q&A live with Dr. Scheiman. So we are ready to start our session.
Thank you for letting me present today at the annual PWSA USA conference. I consider it a tremendous honor, and I welcome the opportunity to talk to you. My talk is entitled A Comprehensive Review of Digestive Issues in Prader-Willi Syndrome. And I do have some limited disclosures and some grant support that I need to mention, and I will be talking about some medications that are not currently approved by the FDA. And if we look at what I'm going to cover, how common are symptoms in Prader-Willi syndrome. I'm going to review some of the published data and give you some information on management approaches, both evidence-based and some experiential in handling children and adults with PWS. And I'll focus on a variety of areas. And if time permits, I'll cover a little bit on some research that I've been doing, as well as covering some information on bariatric surgery. So to start off, well, how common are GI-related symptoms? And if we look at information that has been around for many years, early feeding problems are very common among infants with Prader-Willi syndrome. It's one of the reasons that some children are diagnosed. It's one of the major criteria for the clinical diagnosis of Prader-Willi syndrome. And in a more recent study published in 2003, feeding problems are seen in about 93 out of 100 infants with Prader-Willi syndrome. There are frequent reports of reflux symptoms as well as an inability to vomit. Some early deaths in infants with Prader-Willi syndrome have been thought to be due to aspiration. Some could be due to gastroesophageal reflux. And there, unfortunately, in Prader-Willi syndrome is very significant morbidity from very high pain tolerance and having a difference in vomiting threshold, which can cause problems with recognizing issues that are present. So if we look at the prevalence of symptoms among adults with Prader-Willi syndrome, this was pulled data from a variety of things from Dr. Barbara Whitman, Susie Cassidy, and J.V. Butler. And what you can see among adults with Prader-Willi syndrome, about a third of adults have respiratory symptoms, more than half had sleep symptoms, diabetes was present in about a quarter. Digestive symptoms, surprisingly, were in about a third of the patients. And among those, constipation and diarrhea were the most common. And as a surrogate, if we look over here at the end, skin picking was about as common as having diarrhea or constipation. So not that uncommon. And if we actually look at a more recent study, which was part of the FPWR Registry, about 688 families responded. And what you can see, this is out of the total of 688. And again, light blue is under 2, dark green is over 2. And then how common did it occur? We can see that reflux was fairly common in about 20 to 25% of children under 2 with Prader-Willi syndrome. And this occurred daily. Rumination, which is bringing up food which is not related to reflux, That was seen in a small number of patients, having slow stomach emptying in roughly about 15 to 20% of patients with Prader-Willi syndrome. Gallstones were seen roughly in a small number of patients with Prader-Willi syndrome, less than 5%. Constipation was seen in a good number of patients, roughly in children that were under 2, in about 10% of the kids. In those over 2, it was about 15%. And this was a daily problem that was recognized. And then complaints of belly pain in roughly about 10% of the population of kids that were over 2. So not that uncommon. And again, the mean age of this is a little bit younger than that prior data that I showed you. And then if we look at deaths in Prader-Willi syndrome, GI-related deaths accounted for about 6% of the cases, and with having a GI perforation in about 3%. So roughly about 10% of the causes of death were related to GI. And then if we throw in choking, about 15% of the causes of death in this series from Jim and Carolyn Loker. And if we look at amongst international data, and this was pooled data from Europe, Australia, Japan, and the US. If we look at causes, your GI causes represented in olive were about 10% of the causes. Those related to obesity, not surprisingly, were approximately 40% of the causes. So not that uncommon. And if I couple both GI and aspiration, that would be about 20% of the causes. And again, there's a large number that are unknown and unclear whether obesity was the primary cause or a secondary cause for some of the families and patients. And if we now that we've talked about how common things are, if we start looking at pieces and why this could be happening in Prader-Willi syndrome, I'm going to take you on a little bit of a tour of the GI tract from the mouth down to the anus. And we will highlight looking at the mouth and swallowing. We're going to look at the stomach, and then we're going to look at the lower intestines. And for the sake of time, I will not talk about the liver or gallbladder. If we look at common oral issues, I mentioned to you that one of the reasons that the diagnosis of Prader-Willi syndrome is made is from feeding issues. And oral motor weakness is very common. The muscles are somewhat weak around the jaw. There also tend to, in some kids, smaller jaws and a high palate, which makes it harder to transfer food. And then the small jaw causes some dental crowding, and then there can be some poor enamel creation, and then also erosion from having acid come back into the mouth from either acid in the stomach or from the types of foods or beverages that are consumed. If we look at the saliva actually is often very thick and crusty on the sides of the mouth. And in studies that have been done among dentists, the salivary flow is only about a quarter to half of normals, which makes it then harder to get that food or liquid through the mouth and then through the esophagus because it's not as well lubricated. And the phases of swallowing involve first the mouth and then bringing things back over the tongue, trying to protect the airway area, which is right here, and then clearing it through the esophagus. So these are all definitely challenges in Prader-Willi syndrome, and then looking at different types of therapies and how they can be beneficial. In infants, we did a study way back about 15 years ago where we looked at the duration of NG feeds in children that received occupational physical therapy. Those that received in yellow had a mean duration of NG feeds of about 6 weeks. Those that did not had about 7 months of the requirement for supplemental feeding. Those that received nutritional strategies, again, had about a mean duration of feeds of about 45 days versus about 90. And if you receive both, it was about 35 days. So again, using targeting things to help with positioning, safe feeding, appropriate use of devices, and then using concentrated feeds if appropriate. Those could all help with compensating to cut down on the need for supplementation. And then as we move from the infant into the adult, the swallowing issues may still be present. This was a study that was done by the Pittsburgh group and funded by PWSA USA in 2014. This was published in Dysphagia in 2015, and they used swallow studies in 30 adults with Prader-Willi syndrome. There was not a lot of information provided about these adults, but I think there's some key take-home points here, that there was stuff left in the pharynx, that's that area right behind the tongue near the voice box, and that was in about 97% of the adults that they studied. And there was also slow clearance of liquid and solid from the esophagus in all the patients. And I think the key here is what I've highlighted in light blue is that nobody actually recognized what was there. And so being aware that even if your child has moved forward and is taking in everything by mouth, it's important to be aware that that thick saliva and slower emptying may still be present and may be causing some kind of under the radar issues. There's a study that has, unfortunately, I don't believe, moved forward, which was looking at swallowing and reflux evaluations. Hopefully this will go forward in the next couple of years as a collaborative effort between the US and our European colleagues to get a better handle on long-term dysphagia and swallowing in Prader-Willi syndrome. We look at choking in Prader-Willi syndrome. You can imagine if stuff is staying in the esophagus that there may be issues. From the bereavement program, David Stevenson and I, with some collaborators, looked at the causes of death. And we found that 40% of families had reported a history of choking among 52 that had completed questionnaires. And choking was listed as the cause of death in about 8% of the patients. The average age of these patients was 24 with a range between 3 and 52, and nearly all of them were males. The factors that seemed to predispose to choking were hyperphagia and foraging. You're trying to make that quick grab, having thick saliva, having weaker muscles, because again, it's more likely something might get caught. And then actually at autopsy, there were some findings suggestive that there may be some inflammation in the stomach and possibly some reflux that might be making that esophagus not work as well. And that was in 3 out of the 8 patients that had an autopsy. So what can we do about that? Some interventions to consider would be making sure that anyone who is caring for a child or adult with Prader-Willi syndrome is familiar with how to do the Heimlich maneuver so that you can alleviate obstruction, making sure that there are interventions at diets, with the diet, having supervised meals, making sure that opportunities for food foraging like holidays, now that we're opening up with COVID, making sure that at picnics and those type of events that there's monitoring, encouraging children and adults with Prader-Willi syndrome to use meal pacing and chewing prompts, to use a drink and following up sip and chew policy, using again fluid intake with self-regulation with a straw because that will help with transfer. And then if there's any potential symptoms of reflux or upper abdominal pain, making sure that those are treated appropriately with acid suppression if needed, or potentially Tums. Tums is a calcium supplement. It also is an antacid. So I'm going to move on. And then I'm going to talk about one of my favorite things as a gastroenterologist. I have a stuffed poop emoji in my office. And so we always talk about poop. And so I am going to assume that people have seen this. If you have not, it's the Bristol stool chart. And it's a great way to be able to look for constipation because you can be constipated and be pooping every day. Stools that are constipated would be in the type 1, 2, or 3 range. And sometimes you can actually have what we call overflow incontinence, where you can have small pieces of poop coming out around a large poop ball. And so you can have what looks like diarrhea in the setting of constipation. So how common is constipation in Prader-Willi syndrome? Again, I showed you those surveys at the beginning. This was actually a published study that was done by our European colleagues about 6 or 7 years ago, where they looked at 21 patients with Prader-Willi syndrome. The mean age was about 32, and they were not obese, and they were followed at a center. They looked at the history of constipation, did a rectal exam, and then measured the size of the rectum by ultrasound and looked at how quickly things move through their colon. And they also then compared them to 30 healthy volunteers who were slightly younger in age. And what they found were that about half of the patients with Prader-Willi syndrome had infrequent stools defined as less than 3 per week. And about a third of the patients had some straining, and about a third of the patients reported hard stools. They didn't see any difference in the size of the rectum or how quickly things move through the colon between Prader-Willi syndrome and controls. And then they also looked at a questionnaire study where it showed that about 30% of adults had problems with constipation. And why could there be this contribution? Well, there is a higher prevalence of constipation among patients with developmental delay, especially if you have a decrease in fluid intake, because that causes more drying of the stools, causing it to have more cracks and ridges because more fluid is taken out as it moves through the colon. And then having hypothyroidism is not that uncommon in PWS. It's important to screen for that, making sure that if there's growth hormone deficiency, things that can impact on muscle strength, that those are appropriately covered. And then also having weaker muscles can also contribute because it makes it harder to generate force. And if we look at the positioning, it's important to recognize that there is some anatomy of muscles around the anus that you want to make sure that everything is in a straight position when you're trying to go to the bathroom. Because if you are trying to poop and you're not in a straight up and down position, this allows everything to slide. If instead you're trying to poop at an angle, it's much harder to go to the bathroom. So you want to make sure those feet are square to allow everything to line up appropriately rather than at an angle. And that would imply that for younger children, in the same way with older children, that you don't want to have your feet dangling at the toilet or have somebody trying to poop with their feet, dangling, or they're trying to push that way. Instead, you want to make sure that the feet are square on the ground, that there's good alignment, so you have that nice straight passageway to allow for defecation. If we look at some things that you could also use as adjuncts to help with constipation, you can use Dulcolax if someone can swallow a pill, or use Miralax. Miralax has been shown in some studies, because I know there's some data over on the internet that Miralax is antifreeze. But in studies that have been published out of Children's Hospital of Philadelphia, not among PWS, but among other types of patients, there's been no signs that that's the case. Miralax just pulls more fluid in to make it easier to go. You can also use X-Lax, which is Senna. Senna is also found in prunes. Or there are Senna chews and other forms of Senecot that you can find. I don't typically use X-Lax in Prader-Willi syndrome because I'm concerned about the fact that it's chocolate and that someone with Prader-Willi syndrome may try to binge on that. So using that for either for a little bit of a bowel cleanse, or for maintenance is fine. I've also used in some patients magnesium citrate, but I would advise speaking with a doctor to make sure there's no reason why you couldn't use that for a little bit of a bowel cleanse. For a maintenance dose, I will frequently use milk of magnesia, especially in someone that doesn't drink a lot of liquids, because Miralax, if you can't drink liquids quickly, will not be very efficacious. The other things that are very important would be to make sure that the child is sitting on the toilet for at least 5 or 10 minutes after meals, usually at least twice a day, maybe after breakfast and dinner, to allow that rectum to be emptied. And a good rule of thumb is that you should sit on the toilet for about a minute for every year of your life. So a 5-year-old should be able to sit on the toilet for about 5 minutes after meals. As you get to be about 10 years old, I would cap it at 10 minutes because I wouldn't want someone spending a very long time on the toilet. But using that to make sure that they're trying to sit on the toilet to encourage that rectum to be emptied. And in PWS, making sure that you're getting a good amount of fiber in the diet is appropriate. And then from a very young age, making sure you're getting the child to drink some plain water. So even as an infant, to have a couple ounces a day of plain water so that they're accustomed to drinking that. And then encouraging fluid intake in a safe manner. And again, for children that are preschool age, again, very important to have that toileting regimen, and then using fiber and then agents such as milk of magnesia or Miralax or lactulose. And again, the goal is, again, that toileting protocol to help with emptying the rectum. So again, there are some other interventions that can be used. I did talk about Miralax. You can also use flaxseed or essential fatty acids. Flax is a natural option. And some people will use natural calm, the magnesium powder. You just have to titrate it up to get the effect. But again, you want to make sure with that there's normal kidney function. I don't typically use mineral oil because in Prader-Willi syndrome, there's underlying swallowing problems, and there is a risk with using that type of a product with having that go into the lungs. So again, the key with this is if your child has a problem, that you have to figure that it's going to take at least 6 to 9 months of doing something consistently to really get that rectum decompressed. To only do something for a couple of weeks, you're going to be back in the same place because the rectum has become stretched out to respond to the amount of stool that's present. And so you have to be very diligent. Now, I do want to mention very quickly that there is a problem that can pop up in Prader-Willi syndrome. It's called a rectal ulcer. And it often occurs, I believe, because there is a compound in stool called bile acids. And bile acids are a normal part of stool. And those bile acids, if they sit on the outside of the rectum, can cause itching, similar to what you see with pinworms. And that itching can cause someone to start to scratch their rectum. And the key with this is that you want to get rid of the reason why someone has started the process. So you want to make sure those poops are really, really soft. And then 2, you want to decrease access so we get rid of the behavior. And the ways to get rid of access, one simple way, which I credit the Pittsburgh Partnership for recommending this, which I found it helpful in some very difficult cases, would be to buy a onesie pajamas and then turn them by oversized and then flip it so the zipper is in the back, so that it makes it inaccessible to be able to get to the rectal area while someone is sleeping. And then 2, using, again, those products that make the poop very soft so that we're not seeing that, hard poop sitting in there with fluid still around, and then making sure that there is wiping with a witch hazel pad on the outside of the rectum to cut down on some of that itching, and then making sure we limit the amount of time that someone can spend in the bathroom. This can be a very challenging thing to handle. There are some other things that can be done to help. And the other thing that can also help, which I have down here for older children and adults, then working on, again, if they had this problem that's popped up, they probably have had long-standing issues with learning how to toilet effectively and to poop effectively. So then considering using pelvic physical therapy and biofeedback to help retrain, to make sure you get into the right position to defecate. Those are all things that can help with that problem. There is a medical alert that I helped co-author with James Locher. So feel free to look at that. It's on PWSA USA, and it's available also for sharing with medical providers. So now we're going to talk a little bit about a very concerning thing called gastric dilatation. Again, small and frequent thing that happens, but when it does, it's serious. You can see here, the stomach should be only in this area and that it's occupying more than half of the abdomen. So if we look at this again, this is not in Prader-Willi syndrome, but it was first described back in 1883. It's also been seen in dogs, and it's related to the stomach becoming stretched and then twisting along its axis. In 1859, there was a suggestion that there may be a problem with the nerves in the stomach that contributes to this. And then there's some data, at least in animals, that there may be a problem up in the hypothalamus that contributes to why this can happen. And we all know that Prader-Willi syndrome has a problem with the hypothalamus. So if we look at the stomach and why this could happen, this area here called the fundus is the part of the stomach that can accommodate if you eat more food. This part of the stomach is where typically things are ground and chewed up, and then it empties on into the intestines. So if you eat a large amount of food all at once, or have a large binge, then this part of the stomach can become quite enlarged. And for most people, you would throw up, but in Prader-Willi syndrome, with having a decreased ability to vomit, this may be why it can cause the stomach to become, enlarged. And again, I've talked about this. It's also been shown in patients with anorexia or bulimia. If we look at patients who are being refed on an eating disorders unit, they often complain of belly pain after meals. And it's been attributed in bulimics to binge eating. And then the problem can be that stomach becomes more and more distended. There normally are bacteria in the stomach that can slip into the wall and cause some gas and injury to the stomach, and then cause compression of blood vessels in the stomach. In Prader-Willi syndrome, the first report was back in 1997 by Dr. Wharton, who unfortunately has passed on. He reported 6 women with Prader-Willi syndrome who had vomiting and a gastroenteritis type of picture, who developed rapidly progressive swelling of the stomach, followed by necrosis of the stomach. 2 of the pediatric patients fortunately recovered. 1 patient passed away from sepsis, I believe, probably because the bacteria slipped into the wall and got into the bloodstream. And then out of the remaining 3 patients, 2 of the patients had very massive swelling of the stomach who had to have their stomachs resected. There was also around that same time frame a patient who had Prader-Willi syndrome who underwent a banding of the stomach to try to make the stomach less able to handle more food. And that patient passed away from complications of the surgery about 6 weeks after they had the surgery. And from my reading of the information from that report, it looks like the patient wasn't being supervised because they assumed they had surgery and they would be in good shape, and that they would monitor intake. So if we look at more recent data, again, published by myself and Dr. Stevenson, We looked for this in the PWSA patients who had passed away, compliments of PWSA USA for allowing us to see it. There were 4 patients out of 152 who passed away from confirmed rupture and necrosis, and there were some additional patients that were suspected to have this. One of the patients was a teenager who was not obese, who had been binge eating on a holiday and had, thereafter a belly pain and vomiting. Again, 2 young adults, not obese, again, that belly pain and vomiting scenario. And then there were some middle-aged obese adults who had probably something going on in the stomach that may have predisposed because they had an ulcer. One of them had inflammation in the stomach, and then another child with belly pain and vomiting with some vomiting of blood. So again, out of that registry, about 5% had confirmed. There were some others that were suspected, but these were definitely very high probability cases. So I think the keys for this are it's difficult to diagnose. You have to be aware that it could happen. And again, the goal is not to freak everybody out, but especially this summer as things start to open up more with COVID restrictions, you just want to keep this on your radar. Clinical features, again, would be a change in diet before and then development of belly distension and vomiting. And if your child with PWS, is complaining of a lot of belly pain and their belly seems distended, it may be worthwhile, especially if they don't seem like they're acting like themselves, to take them into the emergency room to get an x-ray. The belly film will show a very large dilated stomach, similar to what I showed you before. And then the key is that we want to gradually bring that stomach size down, with having monitoring to make sure that things are moving in the right direction. Sometimes that requires having a tube placed down your nose to be able to pull that fluid out to gradually bring it down. Sometimes you're able to do that by just using some clear liquids and giving it a little bit of time. So there's a nice algorithm that I helped co-author with Jim Loker that you can find through PWSA USA, which gives you a pathway that, again, you can take into the hospital if this would pop up to give you an idea of kind of what to do. And in this pathway, there is both the part with belly pain and distension, and then there's also some information about constipation on there as well. So, if your child is having kind of recurrent symptoms of, belly pain, and a little bit of distension, it may be worthwhile to consider looking to see how that stomach empties, and then being sure that there's not any underlying symptoms of reflux or that gastritis that I mentioned to you. You could do a gastric emptying study with solids. This should be continued out for 4 hours. We did have a study that was done about 10 years ago and funded by PWSA USA, and I just have not published that yet. I have it on my docket to get it done over the summer, hopefully. And out of that, about 4 out of the 6 patients with PWS had an abnormal or delayed stomach emptying. And the key there would be that they still were hungry, even though their stomach was still fairly full. The things to try, besides making sure you're really treating constipation, because you want to make sure that highway is completely open, would be there are some medicines that you could discuss with your GI provider or with your primary doctor about trying out to see if it will help with the stomach emptying. But again, really making sure you're treating constipation is important. And then sometimes dietary modifications are needed as well. All right, so I've still got some time left. So I'm going to talk a little bit about a couple of other areas. I'm going to hit a little bit on bariatric surgery outcomes in Prader-Willi syndrome and then I may have a little bit of time to talk briefly about some of the research information from some studies I've done. So with bariatric surgery, the principles of that are to either create what we call short bowel syndrome, which means kind of making a bypass through the intestine so you don't have as much area to absorb, or making that stomach smaller so that there's less of an area for you to accumulate, so it hopefully makes you feel full. And those are done by a variety of different methods, both with doing something extrinsically to make the stomach smaller or by putting something in the stomach like a balloon. And this would be an example of a very long highway or a very long bypass. This would be similar to going from Washington, D.C. to Miami without having a lot of area. This is what's called a biliopancreatic diversion. And these have all been tried in Prader-Willi syndrome. And if we look at weight loss at 5 years post-procedure, the Prader-Willi syndrome patients are represented in white, obese patients in yellow. And what we can see is with gastric bypass, again, with any surgical procedure, you really want to know what happens at 5 and 10 years afterwards. Because with most of the procedures at 1 year and 2 years, there will be weight loss. But if you're going to go through an operation, you really want to see at 5 years. Just like if I send somebody for a medical weight loss program, I really want to know at least at 12 months, at least 8 or 9 months after they've been through something intensive, whether it's a weight loss camp or it's some sort of a like Nutrisystem or something like that. You really want to know what's it doing to prevent weight regain. Because if you go through something for a few months, you're going to lose weight. And if it's an operation, you expect at least 1 and 2 years, you should, but you really want to know what happens at 5 or 10 if you're going to take that chance. So what we can see with gastric bypass is that at 5 years in Prader-Willi syndrome, there is at least 3% weight loss. So they're probably close to where they were at the time they had the operation. With the obese patients having at least 10% of their weight lost. And with the vertical band gastroplasty, they actually have gained over their preoperative weight in comparison to obese patients that have still lost 25% of weight at 5 years. So again, these type of procedures with the bypass, there's a little bit of malabsorption, and that may be why there's still a little bit of weight loss, but you're close to your preoperative weight. And with gastroplasty, you're just restricting the stomach. So the thought is that they're stretching the stomach out over time. And if we look at that balloon procedure, again, to give you an idea, these are patients that had balloon procedures, and you can see in green are some of the patients that had more than one procedure over time. And I think it's pretty telling to see both with the patient in blue and these patients in green that over time, the success of the amount of weight loss decreases, I think, because the patients learn how to eat around the procedure. And that's with doing something repeatedly. The complications of using the balloon were significant, and they probably need to be kept in mind as the balloons will probably be becoming more prevalent in use in the US. In the series that was published out of Italy, there were 2 major complications. One patient died 3 weeks after the balloon placement due to gastric perforation, and a second patient developed some concern for possibly developing gastric dilatation about 3 weeks after the bib placement, and especially after solids were introduced. And the complication rate with the balloons in Prader-Willi syndrome was much, much, much higher than in the general population. It was 4 out of 21 versus 71 out of 2,500. And if we look at another type of procedure that's commonly being done in the US to help with weight loss in adolescents because they're concerned about compliance, and this is called a sleeve, which takes the stomach and changes it from a watermelon into a banana. There have been several studies, a total of with 14 patients that were published, including, again, short-term data at 15 months, 9 months, and 2 years. With these patients showing some weight loss, but again, you really want to know at 5 years. And then 9 patients with incomplete follow-up data were published, again, including a 5-year-old and an 8-year-old among some of these patients. And if we look at the experience that was published out of Saudi Arabia in 2016, by Dr. Al-Qahtani with 24 patients out to 5 years. The range in these patients was between 5 and 18 years. They were all obese. They had 100% of them had sleep apnea by sleep study. And then about half of them had hypertension and a quarter had diabetes. None of them had received growth hormone therapy and none of them had any problems with the thyroid gland. And these patients were compared to some obese non-PWS patients who were matched for age and gender and BMI. And what they found was that the Prader-Willi patients represented in light blue, that they did have a decline in BMI. Again, the response was much less than the control patients, but they did have some decline. But you can see that, at 3 years, they're losing, but what's starting to happen? The weight's starting to gradually go back up. And they reported that, that the sleep apnea nearly disappeared in all the patients. But in the follow-up studies, even though these patients were still obese, none of them had a sleep study to look. So again, we advise that cautious interpretation of their data should be done. So now I'm going to spend the last few minutes that I have available to speak to you just to talk a little bit about some of the research studies in Prader-Willi syndrome that I've been doing. The first one, which we've published one paper and we have a second one that's going to be going in for review, hopefully at the end of this month. This one is Modified Atkins Diet and Behavior. This was funded by FPWR Canada. And this was a study duration of 9 months with 3 study visits. Unfortunately, we got this in, back in 2018 and 2019 before COVID hit. And this was using the Modified Atkins Diet. And if we look at the strategies for diet and Prader-Willi syndrome, a typical PWS diet plan might look like this down here in green, with using, a hypocaloric diet with vitamins and food security. And you can see that there is a little bit of kind of vegetable juice and diet jello and a little bit of kind of carb-containing things like a baked potato or steamed rice. And instead, we used a Modified Atkins diet. Not a ketogenic diet. So with the Modified Atkins, the children would get 10 to 15 net grams of carbs. The carbs are determined by carbs, with the difference in fiber. And there was no caloric restriction. And they received roughly about 2/3 of the calories from fat and about 30% of the calories from protein. And again, in comparison to the ketogenic diet, where 90% of the calories come from fat and only 8% of the calories come from protein. The patients that went into the study, we had a total of 7 patients enrolled. And then we had, out of the 7, we had a couple of patients had a difficulty with compliance, with the ability to follow the diet. So again, this is not an easy thing for patients or families to do. What we saw for the patients on the diet was that for the most part, their weight stabilized. These were all patients who had a BMI at least in the 75th percentile, and their weight stabilized without any significant weight gain during the diet. And what we can see with their labs, this is each patient represented individually with what their cholesterol was. So pre-diet and post-diet, and then we can see what happened with the LDL. We can see what happened with the hemoglobin A1C, and their HOMA score, their amount of insulin resistance, did improve for all the patients. And now I'm going to spend a couple of minutes. And then going back to this, we do have data that's being published. That first paper was already published looking at their outcomes. And the follow-up data is looking at behavior and then also looking at the microbiome. And that data should be getting submitted for publication hopefully at the end of this month. The microbiome, I'm going to spend a couple minutes on, is important for development and immunity and for nutrition. And we do know that there is differences in lean versus obese twins with the amount of bacteria present. And these bacteria actually help us be able to scavenge more calories that we need, and then also to provide food for the colon, which doesn't have as much access to regular types of food. And in this, we looked at data from each child and their parent. And I think the key from this, the parents are here in 1, 2, 3, 4, and 5. And what I want you to look at is what the difference in colors are between the parent and the child. So you can see that there are relative differences in each parent with their child and the amount of some of the bacteria that are present, suggestive that those children with Prader-Willi syndrome have a difference in their signature of bacteria and the relative abundance of different things than their parents do. So there is some shared, but there's a difference in the total amounts. And you can see that in the color profile. And if we also look here at pre and post, that there are differences that are occurring by changing the diet, which makes sense because you are what you eat. And so whatever's going in there is going to, whatever the buffet is bringing is going to change those people that are coming to the table. We did see some changes in the diet. Again, I mentioned to you, this is in a little bit different way. It may be easier for some people to see that there are differences in where these bars are meeting, suggestive that between the kid with Prader-Willi syndrome and their parent, not everything is the same. And that being on the diet pre and post, that there are changes in bacteria in the gut. And we can see again, those differences between the children with Prader-Willi syndrome and their parents, and then also the changes that are occurring with the diet. Other things I have looking at this, which very exciting. It's taken a very long time to accumulate data for this study. And this was funded by FPWR, where we were looking at identical and fraternal twins. And I want to thank the collaborators, both the University of Florida and at Loma Linda, for helping us with collecting This data, fortunately, we were able to get 10 families with either fraternal or identical twins, as well as multiple gestations, who were gracious enough to consent and then to ship poop and then samples from saliva, as well as filling in questionnaires. And these all were collected, and we had to quickly end this in February of 2020 before COVID hit and everything would be blocked. There's been a delay in processing of all these specimens because of COVID-related research restrictions, but I'm told by Dr. Argard down at Baylor College of Medicine that these samples are now undergoing processing as of May 15th of 2021. So I should have that data hopefully by the end of this summer, and we will be undergoing statistical analysis and then getting together a very large paper probably for publication in the fall. So for final thoughts, I look at Prader-Willi syndrome and I just totally love taking care of the children and the families. I just was down there last week in Houston. And I look at it as, for all of you, the world is full of challenges, but we have to look with every opportunity that there are opportunities to make life better, and we have to take advantage of that. And so I want to acknowledge collaborators, in many different areas. And then mentors, including Dr. Bill Klisch and my mentors among the Prader-Willi syndrome community, and especially Dr. Phil Lee, and then Dr. Driscoll and Dr. Butler and Dr. Whitman, who have all provided support over time. I want to thank the clinic staff at Texas Children's. I want to thank my collaborators at PWSA, USA, and FPWR, both for funding support as well as allowing me the privilege to speak at the meetings. I want to acknowledge IPWSO, and most importantly, I want to acknowledge families of children with Prader-Willi syndrome. It's one of the things I just love more than anything. And again, this is the Prader-Willi syndrome camp. This year, I don't get to go. I know they're having it down in Texas in San Antonio, and I hope everyone had a great time. I think it'll be the weekend that will be right before the conference. And so I'll take any questions. Thank you so much.
All right, so we have a few questions, Dr. Scheinman. When dealing with occasional constipation, what are some of the best short-term solutions that won't lead to long-term dependence or assistance?
So I think one thing to realize is that if you're even using some sort of a stimulant, whether it's you're using a Senotype product, which is also what's in prunes, that there used to be some thought that, oh my goodness, this is like your bowel's going to become addicted to that compound, and it's actually been disproven. That's been disproven in the last 5 to 7 years. So I think you can definitely use chia or flaxseed; those are fine. You could also use magnesium products, but if you go the route of using a Senotype product, it's actually safe, and it's been disproven that it causes your bowel to become addicted to it. That was a long-standing teaching, but within the last 5 to 6 years, it's been disproven. So, but I think having a good foundation of good toileting and making sure you're being prudent with what you're picking to use based upon how safe it is for your child to drink, those would be things that should be considered.
Thank you. Another question. You have talked about the importance of water intake, but we have found from a very early age that our daughter will not drink water, and I believe that is common. Is fat-free milk a good alternative? That is her main fluid intake.
Again, I think, and I know Dr. Miller says the same thing, we just want to keep trying to offer that, so if you, again, offer it enough, hopefully at some point you will have luck with that. I'd say fat-free milk does have calories in it. So again, it would really depend on, are those calories and that source of protein, is it needed, or are there other options for that? But yeah, if you keep presenting things, again, kids with PWS are a different ballpark, but if you look at a picky, toddler, to really say a toddler doesn't want to do something, you have to offer it to them at least 10 or 11 times. So again, just continuing to offer it on a consistent basis throughout the day, which I think is the same message that Dr. Miller has given during the meeting, is the same message that I use. And, and just trying it, from a young age and being consistent about offering.
All right, thank you. Our 3.5-year-old has bowel movements right after each meal, but is almost always diarrhea. The food is moving very quickly. We tried corn. Is there a way to show the process so her body absorbs more nutrients?
So again, there's a range of normal. So you can poop as infrequent as every other day to as frequent as 3 times a day. And as long as you're gaining weight and growing, some of it depends on the diet and some of it depends on your transit time. So you can have a normal amount of stooling, and that could be within the range of normal. Sometimes you can have a little bit faster transit if somebody, for example, has lactose intolerance. So if that runs in your family, lactose intolerance can start usually at around 2 to 4 years of age, because the diet usually shifts from being like lactose based from either breast milk or cow's milk to, less of that as a predominant thing. So you might want to try like a lactate, type of milk product, or go to one of the other alternative milks. But again, with the alternative milks, especially the nut-based milks, you really want to be sure, since your child is 3, that they're getting protein from other places. So I hope that helps. And then also being a little bit of a detective, looking at, is there possibly some other type of thing that they're not absorbing fully? Because sometimes also fructose, which is a sugar that's in a lot of fruits, can also trigger some people to have a little more frequent stools. But again, that 3 times a day stooling can be normal. Again, if they're gaining weight and growing.
All right, thank you. Do you have any advice in regards to helping with potty training? My little guy always goes once he's relaxed during a nap or at bedtime.
Again, I think this is something that you want to work with their therapist to see when the timing is right, and just, gradually kind of getting used to the process of, maybe after a meal, trying to get them to sit a little bit on a toilet or a squatty potty. But I think this is where you want to work closely with the occupational therapist or physical therapist that's working to make sure that your child has enough muscle strength and that they have the appropriate posture. And then you just want to kind of gradually work towards that goal. It may not come as early as with other kids, but it's definitely doable.
All right. I have to give my son Miralax every day for constipation, but I know that you said water intake is best. But what if they refuse to drink it? So,
okay. Again, water by itself, may not be enough. But you want to try to get, an appropriate amount of fluid in. And if Miralax seems to be the best option for now, then that's fine. Some people are concerned about using Miralax for the long haul. So that's why I was discussing other options besides that. But if it's working okay, that's great. You just want to make sure that with Miralax, that whatever fluid you're putting it in, the fluid is consumed within about 20 minutes or less, because that's how it works. It works kind of like a sponge, so it needs to have that fluid there to be able to do its job.
All right. In a similar vein of what you were talking about, is it best practice to manage constipation via the diet if that is possible? 21-year-old never had GI medication until moving into a group home. Now Miralax twice a day and regular cleanouts due to severity. Home refuses diet changes and he can't move.
So I'm a little confused by that. It's, again, I guess one other thing I should have mentioned when I gave the presentation was a great opportunity to get an idea of if there's constipation that's happening under the radar. Because again, I said people can be pooping every day, but still have constipation. Would be most kids with PWS, at least every couple of years, are getting a back film. And if you specifically, the orthopedist may not look and notice that the child has a lot of constipation, but if you specifically ask during that x-ray, to have the radiologist comment on the amount of stool present, you may actually recognize that there was a problem that was going on for a while. So I usually put that in the presentation. I apologize, I forgot to mention that during it. But if we circle back to this patient, I think, then having a discussion with whoever is the medical oversight for that particular group home about what the options are, for handling things would probably be appropriate. And then potentially making sure that the thyroid functions normal and then looking at other variables would be probably beneficial.
Okay. How can you measure the type and amount of bacteria in the gut?
I muted myself. We don't have great ways to do that right now, because some of that's been limited with COVID. We sometimes do testing for bacterial overgrowth, which is breath testing, but breath testing is only very recently in very selected areas because of COVID starting to open up. There will also be ways coming up soon for being able to do a microbiome analysis. I'd be a little bit careful about doing it now, through an unreliable lab, because you may get data back from somebody that has another agenda for why they're running that for you to try to sell you some things. But I think the best foundation for the moment would be to have a healthy and balanced diet, and then just wait for the other information to come out as it comes. And like I said, we have the twin study, which I've been looking forward to seeing the data. It just took a long time to accumulate the twins, and I thank the families for that, but we should have analysis and then get a publication out hopefully by the end of this year.
All right, thank you. Could diarrhea on and off for 2+ weeks be the sign of constipation or blockage in a 2.5-year-old? No signs of illness or other than multiple mushy and watery stools daily.
So having diarrhea, it could be from constipation. It could also be if the child is around other kids or goes to daycare, you can pick up parasites. It's very common. You can also see it if somebody has been on antibiotics. So that may be somebody that it's worthwhile to talk to the primary doctor about maybe trying a probiotic to see if it helps with the diarrhea. But there can be many different reasons why. And usually with constipation, if it's happening that way, there'd be small little pieces of poop that are coming out and not kind of having mushy and watery stool.
All right, so we were talking about probiotics. Is there a benefit to doing a probiotic? If so, what should we look for in a probiotic supplement? And the same for a prebiotic supplement.
So kids with PWS generally have healthy diets. So I don't know that I would use a prebiotic because most of the prebiotics are fiber-based or inulin-based. So I think I probably wouldn't, because if your child with PWS is eating a reasonably healthy diet, then I don't know that you need to add that. And for probiotics, I probably wouldn't at the moment. I mean, I think if the child's having some sort of a yogurt, then using a yogurt that has active cultures in it would probably make sense to use something like that. But unless your child's on antibiotics or has another reason why, I think I probably would just use a healthy diet, because even when you use a probiotic, that doesn't tend to engraft for the long haul from what we know from data. And I'm definitely not recommending fecal transplants be done because there are some concerning things that are showing up, at least for people that are getting it for clinical indications for kind of long-term problems.
All right, thank you. Would you recommend a modified ketogenic in general for PWS individuals?
I probably wouldn't. I think I would probably recommend, just being thoughtful about the carbs you're eating to make sure they're healthy carbs, they're whole grain carbs, that they have lower glycemic index, because that's going to cut down on the amount of insulin resistance. But I don't know that I would go all the way to a modified Atkins diet. But I think you can probably find those type of principles and to stick also with a modified Atkins diet, even after you do it for a few months, is very hard to follow. But if you use some sort of, thought about the type of carbs and the quality of carbs to make sure that they're healthy carbs and they're appropriate ones, would probably make the most sense.
Okay, thank you. Can Miralax build up over time because it softens the stool, but the person cannot push out the poop?
It doesn't. It's really Miralax. All it really does is it's only there while it's there. It does not build up. So it acts like a little bit of a sponge. So it only has a very short duration of effect. So it's not something that accumulates.
We would like to start our 3-year-old daughter on a fiber supplement. Do you have one that you would recommend?
I think I would probably recommend, talking to whoever is the nutritionist that's working with your child and family about what the current intake is of food, and see if the content of food is appropriate, rather than adding in a fiber supplement, because again, more food-based makes more sense than going with, adding like a fiber powder, because there is some concern that having very high dietary fiber intakes can slow down stomach emptying.
When using flaxseed, is seed better than powder?
I think as long as you're consistent with it, whichever one you're using, you should be okay with either one. But you just want to be consistent and then just be very gradual about going up, and then recognize that there are some calories with using that.
All right. For yogurts, is it important to change yogurt brands to vary the culture strains?
I don't think so. I think, I don't really think that there would be, that much benefit from doing that.
Okay, our daughter has constipation for the last 2 months and have been trying Miralax, lots of fluid, and if needed, milk a mag. We've checked her thyroid, etc., and no change in diet or water intake, exercise. Can allergies affect this?
That would be less common, that would be the reason why. And again, I don't know, how much and what they're doing, because sometimes one of the issues with Miralax can be if a child is sipping on it over a period of time, it's not going to be as efficacious. So I don't, yeah, I think you'd also want to speak with the healthcare provider about if there are any other medical issues in the family besides, the thyroid issue that could be contributing to that.
Okay. Is dairy free? So if dairy free, do they need a probiotic?
Not necessarily, because there are ways that you can get, you can get things in through your diet. So I don't necessarily think you need one. You just want to make sure that you're getting your calcium source, and that you're getting in your calcium and vitamin D, the vitamin D you get from sunlight, but you want to make sure you're getting your calcium source. But I don't think if you're dairy free, you necessarily have to use a probiotic, unless there would be other medications that are part of why you're dairy free, like if your child has food allergies and has some other things going on, that might warrant it.
Okay. What is the best diet for a child who has frequent bouts of gastroparesis?
The best diet would be probably small, frequent meals with a little bit more liquids than solids, and then watching about the type and the amount of food and fiber that's taken in, and then starting to build it that way. And then I think depending on the age of the child, then trying to be sure that you're working with either an adult or pediatric GI provider and a dietitian, so that you're making sure you're meeting the needs that you need, and that there's a good physiologic basis for what you're doing.
Okay. Sugar substitutes, including stevia, have been stated in this conference to promote weight gain. Is there any other way to get more fluids into the teens who grew up with sugar or sugar substitutes?
I think what you could try is using kind of slices of cucumber, or using slices of cucumber, slices of lemon, trying to go that approach, and then do a gradual fade over, from the artificial sweeteners over to those type of things that you're going to be more of a natural approach. And you could potentially make it fun. You could get them one of those infusion cups or infusion bottles to, kind of enhance the excitement of doing it. So that might be a way to be able to kind of subtly do it. Or you could just make it into something new and fun because it's a new summer and, we're going to get outside and we want to try this.
Okay. If an infant received Nissan fundal application with a G-tube, is there something specific to keep watch for? Releasing insulin dumping, GI function, etc.? Thank you.
Okay, so I'm not sure how old this patient is now, and what the reason was they needed the Nissen fundoplication, because I'd say for a lot of kids with PWS, they don't necessarily need it, to be done. But if it's been done, very early on, there is a risk of dumping syndrome, which means that the stomach is smaller and that you're feeding into the stomach, and it can very quickly empty from the smaller stomach into the intestines. So then using a slower feeding method would be appropriate rather than doing a very quick bolus feed, which may just kind of, ping pong out of the stomach into the intestines and then cause blood sugar fluctuations. As you get older, then with age, the stomach will become bigger, and then that wrap that was done around the stomach and the esophagus should stretch out, but sometimes it doesn't completely, or sometimes it can slide. So I think, I'm not sure exactly how old the child is now, but if you have questions, you can feel free to reach out, through PWSA USA. They can reach out to me and I could try to give you some advice.
All right. Well, we had a couple more questions, but we're out of time. We want to thank you, Dr. Scheinman, for your informative presentation.